This is the most common form of breast cancer and also the most common cause of breast cancer-related death. It has not been extensively explored, the use of immunotherapy in metastatic hormone receptor-positive breast cancer. And it's because this group is generally considered to be immunologically cold with few tumor-infiltrating lymphocytes. So what we did was to therefore combine the PD-1 blocking with CTLA-4 blocking, which, and it's been shown, for instance, in melanoma and non-small cell lung cancer, that the combination of CTLA-4 and PD-1 blockage can work even in PD-L1 negative cancers. And then we employed selected chemotherapy in the form of anthracyclines, which in preclinical models are potent inducers of immunogenic cell death. So the idea was to see if we could provoke an inflammation by this chemotherapy and then take off the brakes of that inflammation by these combined checkpoint inhibitors. In addition, we used the metronomic low-dose cyclophosphamide because this has been shown to counter regulatory T cells and myeloid-derived suppressor cells. So again, it was around a selective chemotherapy that we hoped would synergize with the checkpoint inhibitors. And finally, we used pegylated liposomal formulation of doxorubicin because this can be used without steroids, and it limits the heart toxicity also. It was a randomized Phase IIb trial that enrolled 82 patients that were randomized at ratio 2:3 into 2 arms. Arm A got only chemotherapy, while the other arm got the same chemotherapy combined with Ipilimumab and Nivolumab, and it was up to 2 years therapy. And the primary endpoints were safety and progression-free survival. We did not see any difference in progression-free survival between those that got only chemotherapy and the combination arm that included immunotherapy. And the clinical benefit rates was slightly higher in the immunotherapy arm, but with overlapping confidence intervals. It was also a relatively small trial. Regarding confounding factors, we saw that the chemo intensity was less in the combination arm, which may be an issue if it could hide any benefit from EP and Nivo. Regarding the side effects, we saw a high frequency of hypothyreosis, while the other side effects were more or less as expected. We also saw a correlation between high-grade immune-related adverse events and improved progression-free survival. So we conclude that based on these findings, there is not a basis for continuing with further larger studies with this particular therapy combination in an unselected general population of hormone receptor-positive metastatic breast cancer patients. But biomarker analyses are ongoing, and we will see if there is a basis for studies on subgroups.